Hey everyone, I'm going to record these in two parts. First the respiratory, chapter 54 and 55, and then your GI drugs in the last few chapters. Gonna try to just cut, like you see the slides are not real long. I'm just trying to focus on your main points. On your slide here, just talking about upper respiratory disorders. Rhinovirus is what's actually the common cold. I just did your picture for here, so your nasal pharyngeal. This is where all the stuff for the upper respiratory. Acute rhinitis is the inflammation in nasal mucous membranes. Sinusitis is with inflammation into these sinus cavities that you see here. Pharyngitis is down here in the pharynx and the larynx. So decongestants. They start on page 933. They can be here, like topical. This would be a nasal spray, or you take a liquid or a pill, like pseudoephedrine, and then nasal steroids. They all have a different purpose for a nasal decongestant. Any of them decrease the overproduction of secretions. Topical nasal spray cause a local vasoconstriction, as noted here. There should be very little, if any, systemic effect. We just don't know how much is actually absorbed into the system, but it should not be very much. Still have to use caution. If sympathetic activity, as you see the "ene" on the end, and you think about the fight or flight. So if people have glaucoma, hypertension, diabetes, a thyroid disorder, heart disease, a prostate problem like BPH, benign prostatic hypertrophy, you want to be very cautious in using these like phenylephrine, a nasal spray that might have a sympathomimetic effect. Also caution in pregnancy or lactation. These are available over the counter. You instruct people not to use it more than 2 to 3 days because they get a rebound effect where they just have a rebound of this nasal congestion. The main adverse effects are local stinging and burning. Just looking, you have this listed on page 934, table 54-2, and Afrin or oxymetazoline, and your phenylephrine, which is your generic name. I just know it mostly as phenylephrine, are your most common for you to focus on. They are both relieving the discomfort of the nasal congestion. You can read that there. So your oral decongestant is your pseudoephedrine, which is also listed in table 54-2. Everybody should know by now that unlike the phenylephrine is over the counter. Pseudoephedrine is over the counter, but because of abuse, it is now something you have to sign for, and the pharmacist will actually ask you about your symptoms. As you can see, it can be used in pediatric and adults for pseudoephedrine. It decreases that nasal congestion associated with the common cold. Has an alpha-adrenergic, it impacts the alpha-adrenergic receptors in the nasal mucus. So it promotes a decreased drainage by decreasing the swelling of those mucous membranes, and it takes the pressure down. Because of the sympathetic effect, the alpha-adrenergic, it's contraindicated in glaucoma, diabetes, thyroid, heart disease, and BPH, benign prostatic hypertrophy. If it's needed in pregnancy and lactation, you have to weigh out the risk versus the benefit. Avoid if possible. Adverse effects with the sympathomimetic, mimicking the sympathetic or fight or flight response. You can have hypertension, tremors, anxiety, sweating, arrhythmias. Again, this can have a rebound effect if it's used longer than a week. Your last one's your nasal steroids listed in Table 54.2, beclomethasone and your fluticasone, which are the common ones that you will see. But they are steroids, so they're not for immediate relief. It's for chronic allergic rhinitis. If you use it because you've got some swelling, inflammation, if a patient does that, they're not going to get relief because it's for chronic. It takes between 1 to 3 weeks for it to be effective. It relieves that chronic inflammation. It's contraindicated if they have an acute infection going on. And you want to be careful if there's an active infection, pregnancy, or lactation. Should be little, if any, systemic absorption of the steroid, but you never know. The adverse effects are localized dryness, burning, irritation, and possible headache. You do have a box 54.2 on page 935 about administering nasal medications. You want to read over that. You want to make sure they're sitting up. They aim toward the sinus, not squeeze very hard. They should never be forceful. And if you see here on nasal spray, it says to insert the tip about a ½ inch into the open nares. And never forceful, just a gentle spray and sitting upright, but read over that box there. Read over your nursing considerations on 936 about because of the sympathomimetic effect. You're looking for that pulse rate, anxiety, making sure they can urinate, all those things. So look over some of those precautions there. I just was flipping through the pages. All these nursing considerations, they kind of repeat themselves, but I would glance over them. And I know I've taken the textbook a little bit, I'm going in a little bit of a different route than the textbook did, but I'm going to, the pattern that I felt worked better. Because I'm taking in chapter 55, but then some of the things in chapter 54, let me see here. Just, I know like antitussives, antihistamines, some things they put later, but I wanted to bring it in later. So they brought in earlier. I felt it was appropriate later. So into chapter 55 is when we start talking about the lower respiratory. Asthma is the major one we're going to focus on. There is bronchiectasis, bronchitis, COPD, which is chronic bronchitis or emphysema. But I'm not going into detail on those. I know a lot of those systems you haven't really studied very well, so I'm going to touch on what is important for you to know. I don't know why I wrote chapter 55 on there. Probably because that's what talks about lower. Anyway, back into chapter 54. I apologize. Antihistamines are on page 940 in your text. Also, they're listed in table 54.3. That starts on 940, goes over into page 941. All of them block the effect of histamine at the receptor site. They can have anticholinergic and antipruritic, which is itch. That's what they are used for. Anticholinergic, it dries up your mouth. Antipruritic, I said, for itch and welts, used in allergic responses. The first generations are listed on the top part of your, well, there's quite a few of them in the first more than half of this table. Just focus on page 941 on your diphenhydramine, hydroxyzine, and meclizine. Now, these are first generation. They have more of an anticholinergic effect than the second generation antihistamines. So your diphenhydramine, which everybody knows as Benadryl, you can see it's got pediatric and adult doses, and caution in geriatric. Because of such a strong anticholinergic effect, can make people, these first generations can make people very sleepy. The diphenhydramine or Benadryl is very effective for anaphylactic reactions, and I said for pruritus, which is like welts, hives, urticaria, which is all that itching. Hydroxyzine and Visceral, given in multiple ages, seasonal allergies, also used in nausea. Your meclizine, which is also known as Antivert, is for motion sickness. You're going to have people take it about 20 to 30 minutes before they're getting an activity, and I think meclizine is brought up again in the GI section. Promethazine, which is Phenergan, which is also for nausea. It's an antihistamine, has anticholinergic effects, so it does make them sleepy, and it's also mostly used for nausea and vomiting. So I think it might be brought up also in the GI section. On your second generation antihistamines, alistine, I always know it as Astelin, that is a nasal spray. It's a second generation antihistamine. Of course, you should not have a lot of systemic effect, but it's a nasal spray used for allergic rhinitis that's seasonal. Cetirizine, everybody knows as Zyrtec. It's a second generation, and all in the bottom, loratadine or Claritin. So your cetirizine and loratadine are oral antihistamines, second generation, does not have as much as an anticholinergic effect, so it's a little safer and not making people so drowsy. So there might be times you choose to use that. And with less anticholinergic effect, it's safe in asthma, where your diphenhydramine or Benadryl, because of the strong anticholinergic, would be contraindicated in asthma. What else? Said urticaria, non-allergic rhinitis, which is what they call vasomotor rhinitis, motion sickness, I told you about angioedema. All antihistamines are contraindicated with alcohol use. Should tell people not to drink alcohol when they have it because of the increased CNS depression or central nervous system depression. Pregnancy and lactation, risk versus benefit, weight. Avoid them with people with prolonged QT because they can have fatal arrhythmias. The adverse effects, mostly the first generation I told you, anticholinergic and central nervous system depression. That's why I avoid in asthma, and caution if they have renal or hepatic disorders. Just glancing through your text, it never hurts to read that critical thinking scenario that starts on page 543, and glance over your nursing considerations. It starts bottom of 944 into 945. Okay, let's see what our next slide. I pulled this picture from your text because I thought it was just a really good picture showing with the antitussives, which are the drugs to suppress a cough reflex, and the different places each of them work and the effects that they have. That might be a good picture to look at, and you may find it helpful as you're reading over these. So your antitussives, I said it suppresses the cough reflex. It's used for a non-productive cough. Ones where they just have a dry cough, they don't have mucus built up. Page 930, you have that there, let's see. 931, table 54.1, your benzenate, I always call them the Tessalon pearls, or your benzenate, or for this non-productive cough, dry cough, where you don't need to pull the mucus up. It does not have the adverse effects of sedation, so it's very helpful for somebody that has this cough. They need to suppress it. Codeine is an excellent antitussive, so a lot of times it is given in combination with whether it's guaifenesin or sometimes with promethazine, but codeine has a central nervous system depression. It is a controlled substance or narcotic, so you will tell them not to drive a vehicle, operate machinery where they're taking codeine. Dextromethorphan is also for non-productive cough, and hydrocodone, but focus on your your codeine and benzoate. All of these you will use caution with asthma and emphysema because of risk of suppressing that cough reflex. These are people that need that cough. Never use any of these in pregnancy or lactation. Adverse effects are drying, nausea, constipation, dry mouth, GI upset, headache, and dizziness. Your text on page 931, contraindications and cautions, I think it does a very good job of explaining that there, and I've mentioned some of those adverse effects to pay attention to. Let's see, box 54.1, look over your drug therapy across the lifespan. Always look over your nursing considerations. And then onto your expectorants and mucolytics. So let me find your page here. Your expectorants begin on the bottom of page 945. And table 54.4 is on page 946. There's only the one listed, which is your guaifenesin, most people know as Mucinex. Symptomatic relief of respiratory conditions characterized by a dry, non-productive cough. It could be the common cold, acute bronchitis, influenza. As you can see, it liquefies the lower respiratory tract secretions. This is to thin them out, to help them come up, to help with that cough. It's an expectorant. You want that mucus to move. So if it's dry cough where there is mucus built up and you need it to move is when you do the guaifenesin. You use caution in pregnancy and lactation. Use caution if they have a persistent cough because there may be some underlying problem. Adverse effects, nausea, vomiting, anorexia, headache, dizziness. Some people get a mild rash. You want to teach them to drink plenty of fluids when they're taking guaifenesin. Nursing considerations, I'm not sure if there's anything in particular there, just glance over it. Take it with small frequent meals because of GI upset, I think I covered. Okay, so mucolytics begin on page 947. In table 54.5, which is on page 948, just the first one on there, acetylcysteine is the one I want you to know. It's for that person with those very, very thick secretions, like the patient with cystic fibrosis often will be the one that you will see using acetylcysteine, maybe COPDers. They do it in a nebulizer. And when it's administered in the nebulizer, it can cause skin breakdown on their face. So you definitely, after every use, you're going to clean out the mask because you don't want that sitting on the face and causing skin breakdown. Acetylcysteine, mucomist is another name for it that you, in practice, that's probably the word you'll see, mucomist. But acetylcysteine is the generic name that you'll probably see on your exam on NCLEX and on Kaplan. It can be used with COPDers, TB, pneumonia. Use caution if they have bronchospasms, if they have peptic ulcer disease, any esophageal varices, because it can cause a lot of GI upset and irritation. It can cause stomatitis or sores in the mouth, rhinorrhea or runny nose. It can cause bronchospasms and a rash, but the main thing is looking for the skin breakdown on the face when it's used in a mask. The other thing with acetylcysteine, another use outside of the respiratory secretions, it is what's given for acetaminophen overdose. Acetaminophen is Tylenol. Okay, then we're going to move on into bronchodilators, which are into chapter 55, page 954. You see table 55, what is it? 956, table 55.2 covers your bronchodilators. your xanthines, sympathomimetics, and anticholinergics. So your xanthines, aminophylline and theophylline, are used mostly IV. You'll see them in the hospital in emergencies. Your aminophylline you'll see in acute emergencies. Theophylline is not used as much as it used to be, but you may see it in the hospital having a theophylline infusion. Some people are on it orally, and so it's just not used as much as it used to be. But your theophylline, let's see if it covers it in here, it talks about your theophylline. You need to have a therapeutic dose on your theophylline. I'm not sure where that's covered in the text, but your theophylline levels, therapeutic, are 10 to 20. You don't want theophylline toxicity with it going over 20. It causes significant adverse effects. Oh, here we go. Table 55.3. So it talks about having adverse effects under 20 is unlikely, 20 to 25, the nausea, vomiting, and above 30, which hyperglycemia and some other things. So there it is, on adverse effects, trying to keep the theophylline level 10 to 20. Okay. So these xanthines have dilate the airways, symptomatic relief or prevention for asthma and bronchospasms of COPD. It can be used orally, nebulizer, or intravenously. Oh, I'm sorry, xanthines are orally or intravenously. There's a narrow margin of safety. I said the therapeutic level 10 to 20. Caution with GI problems, cardiac disease, respiratory dysfunction, renal hepatic disease, alcoholism, and hyperthyroid. Try to avoid in pregnancy. Never use it with lactation. And the reason the xanthines are hardly ever used anymore is there's tremendous amount of drug interactions. Your sympathomimetics are your albuterol and epinephrine. You will see epinephrine used for anaphylaxis, acute bronchospasms. It is for acute emergencies and anaphylaxis. They are beta-2 selective. Not a lot of them are beta-2 selective. They dilate the bronchi. Even though they're given, the epi is a drug of choice for anaphylaxis, but it is a systemic effect, so it's not used in cardiac patients. Sorry about my confusion there. Your albuterol here is used for what people refer to as the rescue inhaler, because it is used for exercise-induced asthma, for acute bronchospasm, not emergent. So the albuterol is what an asthmatic will refer to as the rescue inhaler. If they're using it for exercise-induced asthma, they will take it 30 to 60 minutes prior to their activity. Any of these, because of the beta effect of these sympathomimetics, fight or flight, caution with any cardiac disease. Just glancing over at your table here, 55.2. Your aminophylline usually reserved for acute bronchospasm emergency. Your theophylline relief of symptoms, prevention of asthma. Down sympathomimetics, there's your albuterol, Preventol. There's a bunch of different names. HFA is your inhaler. You might see an MDI, which is a multi-dose inhaler. It's a handheld. So your long-acting treatment, sometimes people will have an albuterol nebulizer that they use several times a day, 3-4 times a day, and then as their rescue inhaler. What else on here? On top of page 957, the table, there's your epinephrine. You know the EpiPen for your acute bronchospasm or emergencies. Down to, well, Xopenex. You might see, I'm not going to ask you about it, but it's one that's used more often if there's cardiac disease. It's supposed to not have as much of the beta effect to cause the increased heart rate. So speaking of the beta effect, the sympathomimetics, fight or flight, so some of the side effects of the racing heart rate, jittery tremors. Down to your anticholinergics here, ipratropium and tiotropium. You'll see these used more in the COPDers, or those that cannot tolerate the sympathomimetic, the cardiac effect, will use one of these inhalers. It's often used, mostly used for the COPDers. It blocks the vagal nerve stimulation and results in relaxation of the smooth muscles in the bronchi. Ipratropium also comes in a nasal form for seasonal allergies that they can inhale it. Because of the possibility of systemic, although it should not get very systemic, the possibility of a systemic, you want to use caution with anybody, again, with the narrow angle glaucoma, BPH, or benign prostatic hypertrophy, bladder obstruction. Also, ipratropium cannot be used if they're allergic to soy or peanuts. Adverse effect, if absorbed systemically, there's the dry mouth, fatigue, nervousness, dizziness, headache, sore throat, and palpitations. Your text does have the nursing considerations that start on page 961 on the xanthines, 963 on the sympathomimetics, and 966 for your anticholinergics. I don't know if you've covered how to use inhalers. On page 965, it gives you the pictures for the dry powder inhaler. Those often are your steroid inhalants that come that way. There's a little tubing and everything for your nebulizer. You see the little picture on the bottom of page 965 that's using a spacer, which is very, very good. I would look over this on your teaching patients on self-administration, because you may see question about that administration. They use the purse lip, they take a deep, they blow out the air, they puff it in, hold it as long as they can, but read over that on your inhalers and your nebulizer administration. Trying to see if there's other things here. Selective beta-2 receptors, just the albuterol. I have a picture here on the use, but your text has some pretty good pictures there. So I said short-acting for symptomatic relief of asthma. That's what I call it, your rescue inhaler. Onset in 1 to 5 minutes, peaks in 30 minutes, duration 2 to 6 hours. That's why 30 to 60 minutes prior to activity for exercise-induced asthma. It can be given orally, but it really is not as effective. The GI tract kind of impedes the absorption for the effectiveness, and they have more side effects because it comes systemic with the tremors and cardiac problems. And next is drugs affecting inflammation. That's when we get into, we'll start with your inhaled steroids on page 967. Also listed in table 55.4, we'll have your inhaled steroids and your leukotriene receptors. Your steroids decrease swelling and promote relaxation of the smooth muscles and bronchi to prevent bronchospasms. So that's where you will see the asthmatic that is on the inhaled steroid on a routine basis. And the previous picture, we talked about the different on page 965, that little dry powder inhaler, not the best picture of one, but they will have this dry powder that they put the little discus in the mouth and they suck it in. That gives them a dose. Or they might have a multi-dose inhaler or an HFA that they puff, and it has a steroid. Very important to teach them to rinse their mouth after use of the steroid, because they don't want to cause stomatitis or sores in the mouth, or yeast fungal in their mouth. The steroids are contraindicated in pregnancy and lactation. Caution if there's an active infection going on. Adverse effects: sore throat, hoarseness, coughing, dry mouth, pharyngeal and laryngeal fungi, which I mentioned. So you teach them to rinse their mouth. On your table, and just like the nasal steroids, the inhaled steroids are not for acute. Takes 2 to 3 weeks to be effective. Definitely not for emergency. Common ones: beclomethasone and budesonide, which is in your table. Then your leukotriene receptor antagonist block the production of leukotrienes, which is to block asthmatic symptoms. Takes days to weeks to be effective. Again, neither of these are for emergencies. That leukotriene receptor antagonist would be your monticulist, or people know it as Singular. Caution for hepatic and renal impairment. There is fetal toxicity, so you don't want to use in pregnancy. Adverse effects are headache, dizziness, nausea, vomiting, diarrhea. Also elevated liver enzymes. They may have myalgia or muscle pains. Drug-drug interaction, increased toxicity of the leukotriene if they take it with propranolol, which is a beta blocker, or warfarin. Calcium channel blockers and aspirin. They can have toxicity on those if taken with their monticulist or Singular. Look over the little section, nursing considerations, page 966 on inhaled steroids. Let's see. I'm flipping through. On your nursing considerations page, starting on page 970. Elevate temperature to monitor for underlying infection. Let me see, what else does it say? Caution the patient to take the drug continuously, not to stop the medication during symptom-free periods. Because it is a stabilizer, it's not going to for acute things. It's a stabilizer to stop that response, the leukotriene response with the asthma. So it's like a management drug, maintenance drug. So your mast cell stabilizers, that starts, just has one little tiny paragraph on page 971. The only one in its class still is the cromolyn. I've seen it in inhaler, nasal spray, and eye drops, mostly for allergic reactions. So it can be used with allergies or bronchial asthma. And there's not much on this, and I'm not sure that I've seen that around in a while. If you can find it, it works well. And I think that's it for this section. Let me double check. Okay, I believe I covered the key points that I want you to do in this section. I'm going to end this recording, and then you'll have one more recording on your GI drugs.